Welcome to tulipoet.com.
Occupational English Test. Listening Test. Part A. In this part of the test, you'll hear two different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1. Questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Mrs. Wilson.
Hi, Doctor.
What can I help you with today?
Well, I've got this kind of numbness and tingling in my hands. I'm a bit worried I might have some kind of problem with my circulation. So I thought I'd see if you could find out what's causing it.
I see. And how long have you been experiencing these kind of symptoms for?
Well, some time really. At first I didn't notice it because it was very mild and it didn't happen very often. I just thought, well, my hands are falling to sleep. It's no big deal. I suppose about 3 years, right from the time I first noticed it.
I see. So is there any part of the hand in particular that's being affected by this?
Well, it's mainly my thumb and my first 2 fingers. The inside half of my hand, I suppose.
I see. So it's the kind of pins and needles? Would that be an accurate way to describe it?
Yes.
And is there any pain accompanying this?
No, not really. It's more numbness, and it's becoming increasingly noticeable and happening for longer periods of time.
I see. And is there any particular time of day or particular activity that seems to be associated with it?
Well, I sometimes drop things, like if I'm carrying something like a cup of tea or coffee and it slips out of my hand, and I wonder if it's normal or not.
I see. I meant was, is there anything that could be the cause of it, rather than the effect?
Well, I often notice it when I first wake up in the morning. That's why at first I thought it was just because I might be sleeping on my hands or in a funny position. But I've noticed it at other times too, so I'm starting to question that assumption.
I see. And how about trauma in the past? Have you ever injured your hands or wrists in the past?
No, not at all.
How about your neck or your spinal cord?
No.
Okay. While we're on the subject of your medical history, have you ever been hospitalised before?
Well, only when I was giving birth to my son.
I see. And any complications during that pregnancy?
No.
Do you have any other medical conditions or even allergies?
No.
So I suppose you're not taking any medication then?
No.
Okay. I'd also be interested to know if anyone else in your family has ever complained of anything similar, this numbness and tingling in the hands.
My mother's actually had some problems with the feeling in her hands, but she was a data operator for 20 years, and I suppose it's not surprising she's ended up having problems in that regard.
I see. And any other relatives with this kind of problem?
Not that I know of, no.
I see. And are you working at the moment?
Yes, I'm a real estate agent.
Okay, and do you think there are any activities that you do at work that could be contributing to this?
Extract 2. Questions 13 to 24. For questions 13 to 24, Complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. May I know your problem?
Well, I'm having asthma and facing difficulty in walking even 10 steps. My weight is 344 pounds. I have high cholesterol and high blood pressure. I have joint pain, back pain, foot and ankle pain, and swelling on my leg and foot. I have sleep apnea and snoring. Moreover, I am a diabetic patient on medication. I also have hemorrhoids, doctor. I am also pursuing surgical attempts for weight loss and to become active in my life again.
What's your age?
37, doctor.
Okay, do you drink or smoke?
I do smoke, and I have stopped drinking alcohol a year back.
Have you undergone any surgeries earlier?
I underwent orthopedic knee surgery, doctor.
Can you brief me about your family history of diseases?
All my family members have obesity, heart disease, and diabetes, and negative for hypertension and stroke. But I am using Chantix to come off smoking completely.
Okay, tell me about your food habits.
I eat things like bacon, eggs, and cheese, cheeseburgers, fast food.
How many times do you eat in a day?
I eat 4 times a day, 7 in the morning, at noon, 9 p.m., and 2 a.m.
Well, the ideal weight for your age is 184 pounds, and you are weighing 344 pounds. That means 184 pounds in excess. What medications are you taking?
Diovan, Crestor, and Tricor.
Do you have any chest pains or any mild attacks?
No, doctor.
Well, your cranial nerves 2 through 12 are intact. Neck is soft and supple. You have positive wheezing bilaterally. Heart rhythm is normal. Abdomen is soft. You have 1+ pitting edema. I have reviewed your complete test reports. This is a clear case of bariatrics, and you need to go for a laparoscopic Roux-en-Y gastric bypass. The complications include infection, bleeding, pulmonary embolism, deep venous thrombosis, leakage from the gastrojejunal, anastomosis, and possible bowel obstruction. Before we proceed for the surgery, you need to get reports on upper endoscopy, H. pylori testing, thyroid function tests, LFTs, glycosylated hemoglobin, and fasting blood sugar.
Okay, doctor. I would like to proceed with the surgery.
That is the end of Part A. Now look at Part B.
Welcome to tulipoet.com.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
Hi, Dr. Mitra?
Yes.
I have a patient I'm ready to present whenever you're ready.
Sure, go ahead.
Okay, so Mr. Ferguson is a 64-year-old male with a history of diabetes, hypertension, and hyperlipidemia who comes in with a chief complaint of chest pain for the last 3 days. He described it as a substernal burning, and he gets about 5 to 10 episodes a day. He first noticed it after he was drinking some tea, but then he's also had multiple unprovoked episodes as well. The pain is neither exertional nor is it pleuritic, and it doesn't radiate to his back or anywhere else. He does get some shortness of breath with the pain, but he doesn't have any nausea, vomiting, or diaphoresis. He doesn't have any leg swelling, fevers, cough, or abdominal pain either. Mr. Ferguson takes glyburide, lisinopril, and simvastatin. He doesn't have any drug allergies, and he doesn't smoke. On physical exam, Mr. Ferguson's vital signs were unremarkable. He's comfortable and well appearing. He doesn't have any JVD. His lungs were clear. His heart exam was with a regular rate and rhythm without any murmurs, gallops, or rubs. His abdominal exam was benign, and he did have intact and symmetric distal pulses without any lower extremity edema or tenderness. His EKG is here. I looked at it, it looked like it was in normal sinus rhythm without any acute ischemic changes. For my assessment and plan, Mr. Ferguson is a 64-year-old gentleman who comes in with multiple cardiac risk factors with the chief complaint of substernal chest pain. For my differential, the fact that the pain is burning and he notices it mostly after tea makes me think of something GI like reflux as the most probable diagnosis, but he does have multiple cardiac risk factors and he has had the spontaneous episodes of pain as well, which make me concerned enough that we should rule out the acute coronary syndrome. He doesn't have any pleuritic pain or any signs or symptoms of DVT to make me strongly suspect a PE. He doesn't have any tearing pain, he's normotensive, and he doesn't have any pulse deficits to make me strongly suspect a dissection either. For my plan, I'd like to get a CBC, a BMP, a set of cardiac biomarkers, a chest x-ray, and give him aspirin. Currently he's chest pain free and we can reassess the need for further analgesia later. For disposition, Mr. Ferguson, if his first set of enzymes comes back negative, I'd still like to bring him into our chest pain observation center to complete a rule out and get a functional study in the morning.
Great assessment and good plan.
Thank you.
Question 26. Now read the question.
This is the first UMC visit for Jonathan, who is a 24-year-old African-American with a history of sickle cell disease who presented to the emergency department with a 2-day history of bilateral knee pain. He's ectomorphic and is in moderate distress. The pain began Tuesday at approximately 4 a.m. While he was working a night shift at Walmart. He had difficulty sleeping because of the pain that night, and the pain gradually continued to increase due to a severity of 8 out of 10 today. The pain was exacerbated with walking and standing and was not significantly relieved with Percocet, which he received from another physician that we aren't sure who it was. Jonathan has never experienced knee pain to this extent before, but he did say that he's had a few episodes in the distant past of knee pain. He reports some chills and mild shortness of breath, but he denied fever, nausea, vomiting, cough, chest pain, abdominal pain, or recent trauma to the knees. He has no other known medical illness and isn't on any chronic medication for sickle cell disease either. In the ED, he was given an IV bolus and received 2 doses of morphine at 6 milligrams and 8 milligram doses.
Question 27. Now read the question.
So this is Mr. Gervais. He's a 79-year-old male with a history of thyroid carcinoma, originally diagnosed in 2006. We had a thyroidectomy as well as ablation, which reoccurred in April of 2009 in his thyroid as well as his lung. Also has a history of diabetes, OSA, paroxysmal atrial fibrillation, hypertension, bladder cancer, status post of TURP, and BCG. Who came into the Wilmington ED early this morning, status post the PEA arrest at home. He, at home, had been complaining of worsening shortness of breath times 1 week. When they called EMS and they arrived at his house, he was noted to be in severe respiratory distress in the tripod position with an O2 sat of 68%. He subsequently became bradycardic and went into a PEA arrest. He was intubated in the field and received 2 rounds of CPR as well as epinephrine and atropine with return of spontaneous circulation approximately 8 minutes after he lost his pulse.
Question 28. Now read the question.
So Ashley is 2 weeks old, and she was admitted from clinic today with a fever. And mom checked it in Ashley's armpit. It was 102 degrees, and when we checked it rectally, it was 101.5. She also noticed some nasal drainage and some fussiness, but she's been feeding well, right? Yeah. She's been breastfeeding normally, normal amount and everything. She's had no trouble breathing. She's had 4 bowel movements in the last day, and they've been yellow and seedy, which is good. And she's had 8 wet diapers in the past 24 hours with no odor change, no color change, no extra amount. You both said she's been moving around well.
Right, yeah.
And she reacts to your voices and everything.
Yes. Mm-hmm.
And she's had no other problems besides the fever and the little bit of congestion and the fussiness.
Not that we've noticed.
Good, okay. Ashley was born at 39 weeks via spontaneous vaginal birth, and your water broke around the time you delivered.
Yes,
right?
That's right.
Mom and dad are married and monogamous. They don't have any other children, but they did have some school-age cousins visit last week, but they seemed well when they were around.
Question 29. Now read the question.
Good morning, Sophie, and this is Alex, and I think it's his abdomen that we needed to examine this morning, isn't it? I can see that his tummy looks nice and flat, it isn't distended, there aren't any scars, and it's moving nicely, thank you. It's moving nicely with respiration, which tells me that his tummy's not hurting at all. I'm next going to do superficial palpation, so just gently feeling round the tummy, going all the way round, making sure I feel in all 9 areas of the abdomen. And what I'm mainly doing here is checking to see if it hurts anywhere. So I'm not really looking at his abdomen, I'm more looking at his face to see if it's tender anywhere. And it certainly doesn't seem to be tender, and I can't feel any hard areas or any guarding. So that's fine. After superficial palpation, we go on to deep palpation, and I'm starting the right iliac fossa, and we palpate gently with each of his respirations, moving up towards his liver, and ending with your index finger parallel to his rib margin, and I can just feel the tip of his liver there, which is perfectly normal in a child of his age.
Question 30. Now read the question.
Years, I think palliative care, which is really, the idea is that it's a form of specialized care for patients with serious illness, where the focus is really on supporting the best possible quality of life while living with their illness. Palliative care has grown as a field, and there are now more than 5,000 palliative care specialists in the United States taking care of patients in hospitals and clinics and other settings. And I think that the field has helped us learn a lot about best kind of communication practices. And I think that the kind of general principles that would come out of what we know from palliative care is that patients have different understandings of their illness. We saw with Debbie that she had an unbelievably kind of acute understanding of her illness. She knew where she was. She knew what she was up against. She wasn't, in a state where she was kind of pretending at all. She was very self-aware, and she had agendas of her own and goals that were really important to you. And I think palliative care really focuses on beginning with the patient and his or her family, and what's important in that context.
That is the end of Part B.
Welcome to tulipoet.com.
Occupational English Test. Listening Test. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
I grew up in the Midwest, and my folks had a friend who was a podiatrist, foot doctor. And when I was a little kid, I said, I think I'm going to be a dentist. So this gentleman met me one time at the water ski club we were in, and he said, "What are you going to do with your life?" I said, "I'm going to be a dentist." He said, "Great, why?" I said, "I don't know. This just sounds like a good idea." He said, "Well, why don't you come visit me in my practice sometime and let me show you what goes on?" And I did that a number of times. And then when I went to the University of Iowa, he introduced me to some doctors that were up that direction. And I was just sold. I was enamored by the fact that you can have someone come in discomfort and you can make them feel good on the spot. And I was sold.
Let's go over some chiropractic terminology. People hear these terms, but they don't really know what they are. What are corns?
Well, podiatric terminology is very common, and corns basically are accumulations of skin on the toes. Generally, it's associated with a toe that instead of laying flat is bent. And so what happens is shoe pressure will accumulate tissue. That tissue is called a corn. That, in turn, actually makes pressure on the nerve underneath and is uncomfortable. So most people think a corn is a growth. You kill the growth and it goes away, but it's really the deformity of the toe, generally the bending of the first knuckle in the toe, that is the underlying cause of the problem.
What about a bunion?
A bunion is also a deformity of the foot that happens to be congenital in origin. So a bunion is where the first metatarsal bone in the foot drifts towards the other foot. Now, most people look at a bunion and they see a bump on the side of the foot and they think, I just grew a bump on my foot. But in reality, it's a shifting of bone. And that then is associated with the big toe moving towards the small toe side of the foot. This then accentuates the hammer toes that are oftentimes associated with the corns we just spoke of.
Bone spur?
Bone spurs are accumulation of bone, and these typically will occur where there's traction. For instance, in the Achilles tendon, we frequently see athletes who have Achilles tendon traction type spurs. These project off of the back of the heel bone. And what happens is a runner, for instance, or someone who does a lot of basketball or other court activities, they develop that calf muscle and it gets real strong, but it gets short. And that makes the Achilles tendon pull a little harder on the heel bone. That creates traction, and that traction creates growth of bone. A similar spur is one on the bottom of the heel, which is traction of the ligament called the plantar fascia as it pulls against the heel bone in its pathway going up towards the toes. This is oftentimes associated with a flat foot or also associated with a shortened Achilles tendon.
How can people tell if they have an arch problem?
Generally, you can tell if you have an arch problem by looking at your ancestors, the heredity nature of the thing. So, for instance, if you have an arch problem, or you think you do, and you just simply have a flat arch, but if you look at your parents, grandparents, or siblings, and nobody has any associated deformities, such as bunions, you generally don't have to worry too much about it. But the easy way to do it is have someone else eyeball you from the back as you're standing barefoot, looking away from them, and look at the Achilles tendon's direction downward. If the Achilles tendon direction downward is pretty much perpendicular to the ground, you generally don't have much of an arch problem. If it deviates outward towards the small toe side of the foot, then you generally know that you have some arch problem.
We've often talked about the shoes that people select, especially women's shoes. What's been your experience about the selection process for shoes?
Well, it's real interesting you ask that, because there's been a phenomenon now, especially in the sports world, where people are going to, in quotes, barefoot running or unconstructed shoe running. And they're thinking this is getting back to nature and so forth. But I've already accumulated a handful of people with metatarsal fractures. The last week I had a young lady who had a 2-inch piece of wood stuck in her foot with a very deep infection that we had to take to the operating room. So as far as athletic foot gear, what we always talk about is get the proper shoes for the proper sport. So for instance, most of us say the word tennis shoes when we mean any athletic shoe. Tennis shoes are specific for the sport of tennis. They're flat. They don't give a lot of arch support. They're not meant to, and they're not meant for running. So if you're a runner, get a good quality running shoe. If you do court sports, basketball or what have you, get a court shoe. Now, women's shoes. Women typically are wanting to wear, especially in their younger years, an elevated heel. If you wear a little bit of an elevated heel, 1.5 to 2 inches, probably no problem. If you have a little bit higher than that and the sole is raised, so you have sort of a platform effect, not much of a problem either. But if you wear in the 2-inch to 3 to 4-inch range, frequently what happens is, number one, you load so much pressure on the front part of the foot that if you have one of those deformities we talked about earlier, such as bunions or hammer toes, you put more pressure on it, you make it grow faster, even though its origin was heredity. Now, the other thing that you do, if you're a woman and you're wearing high heels all the time, is you ultimately shorten your Achilles tendon. As your heel goes up, your Achilles tendon relaxes. Nature doesn't like a void like that, and it will shorten the tendon. That makes it uncomfortable to wear flat shoes in later life.
So that the old expression we talked about earlier, Jimmy Choo may not be for you. Is that correct?
Jimmy Choo may not be for you, or at least maybe only one day a week.
All right. Tell us about the things that you can do now as a podiatrist that you couldn't do 10, 15 years ago.
You know, it's really neat to watch medicine evolve, and you've seen it in all the fields that you interview, but one of the nicest things we have are these miniature instruments now. So, for instance, again, for the athletically endeavored type person, a lot of people develop bone spurs, as we talked about, around the ankle bone. And it frequently occurs with people who do basketball and other court-type activities. And these spurs in days gone by used to be somewhat disabling, and they used to be a major project to get them gone. We'd have to make a big 3 or 4 inch opening and use hammers and chisels and so forth and take them out and lay somebody up for quite a while. Nowadays we have these miniature scopes. They're 4 millimeters in size. We make a small opening on one side of the ankle. We put a scope in which is attached to a miniature TV lens. We look at the TV monitor, and on the other side we put little vacuums and drills and suction devices to clean things out. Usually requires only a stitch on each side, and that takes care of the problem. Another one that I'm really excited about is also the use of a scope, and it's also a 4mm scope, and that's for people that have painful heel spurs. So most heel spurs we get better with typical type of treatment known as physical therapy, stretching exercises, orthotics, shoe devices. In those rare cases that people don't get better with it, we can treat this with a scope. I go in with a little 4mm opening, release the ligament known as the plantar fascia. It's literally a 5-minute operation, and the patient walks away. They have a stitch on each side of the heel, and within about 4 days, they can take a shower again, and they're back to their regular activities in 2 to 3 weeks. Another one that we've talked about maybe a couple times before is shockwave therapy. Now, we have ultrasound, which is the physical therapy type thing where you put a sound wave on someone and you warm up the body part. But we have ultrasound now so powerful that it can fracture kidney stones. In kidney stone removal, it's called lithotripsy. In the foot, to remove the effect of bone spurs, it's called shockwave therapy. So essentially, a large machine is utilized, and it is applied to the area where the bone spur is, and it literally dissolves the problem.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Hello, doctor. Can you explain how vulvovaginal candidiasis infection occurs, its symptoms, and its treatment?
Vulvovaginal candidiasis is a syndrome rather than an infection, and diagnosis of vulvovaginal candidiasis does not rely on clinical or laboratory criteria alone, but a combination of these two. Usually, vulvovaginal candidiasis is caused by C. albicans, but can occasionally be caused by other Candida sp or yeasts. Typical symptoms of vulvovaginal candidiasis include vaginal soreness, pruritus, dyspareunia, abnormal vaginal discharge, and external dysuria. However, none of these symptoms are specific for vulvovaginal candidiasis. About 75% of women will have at least one episode of vulvovaginal candidiasis, and 40 to 45% will have 2 or more episodes. Based on clinical presentation, microbiology, host factors, and response to therapy, vulvovaginal candidiasis can be classified as either uncomplicated or complicated. About 10 to 20% of women will have complicated vulvovaginal candidiasis, requiring special diagnostic and therapeutic considerations. Types of uncomplicated vulvovaginal candidiasis are sporadic or infrequent vulvovaginal candidiasis, mild to moderate vulvovaginal candidiasis, likely to be Candida albicans on immunocompromised women, Complicated vulvovaginal candidiasis are recurrent vulvovaginal candidiasis. Several vulvovaginal candidiasis, non-albicans candidiasis, women with diabetes, immunocompromising conditions, debilitation, or immunosuppressive therapy. By the presence of symptoms such as external dysuria and vulvar pruritus, pain, swelling, and redness, a diagnosis of Candida vaginitis is suggested clinically. Signs include fissures, vulvar edema, excoriations, and thick, curdy vaginal discharge. The diagnosis can be made in a woman with signs and symptoms of vaginitis when either a Gram stain or wet preparation of vaginal discharge demonstrates budding yeasts. Pseudohyphae, hyphae, or a culture or other test yields a positive result for a yeast species. Use of 10% KOH preparation in wet preparations improves the visualization of mycelium and yeast by disrupting cellular material that might obstruct the visuality of yeast or pseudohyphae. Examination of a wet mount with KOH preparation should be performed for all patients with symptoms or signs of vulvovaginal candidiasis. For patients with negative wet mounts but existing symptoms or signs, vaginal cultures for Candida should be considered. In case Candida cultures cannot be performed, then an empiric treatment can be considered. Identifying Candida by culture in the absence of signs or symptoms is not an indication for treatment, since approximately 20% of women harbor Candida sp and other yeasts in the vagina. However, postcoital testing for yeast is not approved by Food and Drug Administration. Culture for yeast remains the gold standard for diagnosis. Vulvovaginal candidiasis can occur concomitantly with sexually transmitted diseases. Most healthy women with uncomplicated vulvovaginal candidiasis have no identifiable precipitating factors. Short-course topical formulations effectively treat uncomplicated vulvovaginal candidiasis. The topically applied azole drugs are highly effective than Niacin. Treatment with azoles results in relief of symptoms and negative cultures in 90% of patients who complete therapy. Over-the-counter intravaginal agents clotrimazole, 1% cream, 5 grams intravaginally daily for 7 to 14 days, or clotrimazole, 2% cream, 5 grams intravaginally daily for 3 days, or miconazole, 2% cream, 5 grams intravaginally daily for 7 days, miconazole, 4% cream, 5 grams intravaginally daily for 3 days, or miconazole 100 milligram vaginal suppository, 1 suppository daily for 7 days, or miconazole 200 gram vaginal suppository, 1 suppository for 3 days, or miconazole 1200 milligram vaginal suppository, 1 suppository for 1 day. Teoconazole 6.5% ointment, 5 grams intravaginally in a single application. Prescription intravaginal agents butoconazole 2% cream, 5 grams intravaginally in a single application, or turconazole 0.4% cream, 5 grams intravaginally daily for 7 days, or turconazole 0.8% cream, 5 grams intravaginally daily for 3 days. Turconazole 80 milligrams vaginal suppository, 1 suppository daily for 3 days. Oral agent fluconazole 150 milligrams orally in a single dose.
That is the end of Part C. You now have 2 minutes to check your answers.